Hello and welcome to the Imaging Wire Show. My name is Brian Casey, Managing Editor of the Imaging Wire. Got a great show for you today. Our topic is starting a CT lung cancer screening program. The National Lung Screening Trial in 2011 established that low-dose CT lung cancer screening of high-risk individuals like smokers can reduce lung cancer mortality by at least 20%. But since the release of NLST, CT lung cancer screening has struggled to win widespread acceptance. In this episode, we're going to be discussing how to overcome some of the challenges to setting up a CT lung cancer screening program, and also some of the technologies that are available to perform CT lung cancer screening effectively and efficiently. Our guests today are Dr. Chip Gilkeson, Vice Chair of Research and a Professor of Radiology at University Hospitals Cleveland Medical Center, and Steve Worrell, CEO of Riverain Technologies. Gentlemen, thanks for being with us today.
Thank you.
Thank you, Brian. I appreciate the opportunity.
Yeah, look forward to it.
So can you tell us a little bit about yourself, Chip?
Yeah, I am a card-carrying cardiothoracic radiologist. I've been here at University Hospitals Cleveland Medical Center for about 28 years. I'm a dedicated cardiothoracic radiology, certainly the basis of my interest in certainly lung cancer screening. And that's really my background. I also I've always been interested in optimizing visualization of chest diseases, and I think we've had a very fruitful relationship with Riverain for years about how to optimize visualization of disease in the chest. So I look forward to talking to you guys about that.
Very good. Steve, how about you?
All right, Steve Worrell, CEO of Riverain. So I took over as CEO of Riverain in 2013. Riverain has 6 FDA-cleared CE marked applications. All of those applications are centered on the chest, and so our focus is cardiothoracic diseases.
Very good, thanks. So let's get right into it. NLST showed a 20% mortality benefit to CT lung cancer screening, and the Dutch Nelson study showed a mortality reduction of 24% in men and 33% in women. So studies show that CT lung screening really works. Chip, has that been your experience there?
I think our experience is that lung cancer screening does work. And a lot of our results really echo and support the Nelson and NLCT. If we look at our populations who have been screened, we clearly have improved already in the last, now it's been 10 years, but have demonstrated a difference in survival in our population. We've demonstrated with some research is what they call, the oncologists would call a stage shift at the time of first diagnosis of patients with lung cancer. When we use lung cancer screening, when patients are diagnosed with lung cancer at university hospitals, they're usually diagnosed at an earlier stage because we a lot of times diagnose them with lung cancer screening. So yes, it has been an effect. It has been a significant effect.
So you started 10 years ago, and so that was just maybe a couple years after the NLST came out. What was the reason that you guys decided to really jump into CT lung cancer screening back then?
Yeah, so Brian, I think it's a very interesting story, and I think it really segues to a lot of our efforts and interests at our hospital and our hospital system, which is optimizing and making screening available to the at-risk population. So I think the real interesting the background is that we started actually, and I think one of the things that enabled to do lung cancer screening well was we had started a coronary calcium screening program. And we eventually went to a zero-cost coronary calcium screening program. So we had in place mechanisms to screen patients for diseases. We had mechanisms to getting patients in the door. We had mechanisms to identifying them and screening them. And this is important when you start a program, you need some real significant support and some background and framework to do this. That's what we did as our background. And with that in mind, so it's good that Brian, you talked about the NLST, because that year, actually, I get a call. I was at the hospital. I got a call from the head of our cancer center. And he said, "Hey, Chip, I'm at this conference at the ASCO, and they just presented this NLST data." He goes, we've got to get ahead of this. He says, "This data is amazing. This is significant data, and we have to do this and anticipate that may take a little bit of time for the payers and insurance to catch up with this. But if we can, and again, we utilize our background of screening with calcium scoring and apply that background and infrastructure to lung cancer screening, we can make this work." But it really came from our clinicians and our oncologists who said, "Yeah, this data is significant, and we should really be offering this for our patients."
Pretty high burden of smoking in your patient population there at university hospitals?
Yes, and I think that's particularly, why this becomes such an important effort, because if you look at the demographics of lung cancer and smoking and risk, our area of the world, which is sort of the industrial Midwest, particularly in our area of Northeastern Ohio, traditionally ranks in the top decile, quartile, in terms of lung cancer incidence per 1,000 patients. So we really have, and particularly in our group, in our demographics, the African American smoking population is a particularly at-risk population for lung cancer, and particularly is a significant, our Northeastern Ohio, particularly in Cleveland, our demographics are, we have many African Americans, many industrially, we've got industrial pollution, we've got smokers, a lot of smokers. So yeah, for us, we realized, and probably why the head of our cancer center called me and says, "Chip, this is really important to our community and the community that we serve, is to be able to offer this screening program."
So NLST has shown a mortality benefit. Nelson showed a mortality benefit. You guys have had a good experience with it, and yet uptake of CT lung cancer screening across the U.S. is pretty low, and is quite a bit behind other screening studies like mammography and things like that. And the numbers that I've seen range from, upper single-digit % to, I think there was a study that came out earlier this summer that showed 21%, which was the highest that I've seen yet, but it's still a lot lower. Why do you think that is?
Yeah, I think that there's and yeah, I agree with you that difference in that lag of percentage has been widespread everywhere, whether it be both in the US and even in Europe and in Asia. And I think I was thinking about, as you had we talked about this a little bit before, probably about it's obviously is multifactorial, but I think there's probably three factors I was thinking about. I think one is, our patient population, the smoking population, we already know that in many ways, I think they recognize that they're engaging in a health behavior that's probably not very healthy. I think a lot of this, part of this is, I think, that patient reluctance to find out about the results of the health behavior. And that's an important thing to recognize. And I think that what's interesting to talk with my my PCP colleagues, my internal medicine colleagues, is, and they share that experience, which is it's hard to intervene a lot of times, because a lot of times the patient is reluctant. So I think there's patient reluctance sometimes. And I think this, which is, and though we've made some inroads, I still feel that the provider education, identifying the patients who are really at risk, making sure, and we try to be very active, and as part of being a program, they have to be very active about getting out both for education purposes. This program does exist for your populations. Make sure that, and very simple interventions, identifying, their smoking history. Do they actually qualify for it? Are there ways that we can be creative, at least to look at the medical records, to itemize these are at-risk patients, and we actively reach out to them. So that's number two, is probably in provider education, and that takes some time, and I think and some background and some infrastructure. And third, in some ways, I think there's a little reluctance even on the basis of the institution, because do they have the manpower, do they have the infrastructure to provide the service? Because I think about some of the decisions, and even the VA medical system had a long time, because they sort of recognized the amount of infrastructure and support to support these programs is pretty significant. So I think it's a combination of both patient, reluctance, provider education, and sometimes some institutional reluctance to be able to really provide those supports.
Now, Steve, Riverain makes software that supports CT lung cancer screening. What are some of the issues that some of your customers are seeing when it comes to setting up and performing CT lung screening?
Well, I think, I think the overhead, if you will, on the provider side is definitely a factor, right? Sort of reporting to the registry. And so, as Dr. Gilkeson said, I think there's still a lot of room for improvement with respect to education. I also think that radiologists, their reading burden volume is already quite high, so taking on additional volume. And so that is really where we felt like we could make a difference, right? To provide a software application that sort of streamlined the reading process, improved accuracy, and integrated seamlessly into the workflow. So that was sort of a contribution that we felt that we could make. But I think once programs get underway and they sort of hit their stride, so to speak, right? So they've sort of integrated this additional patient volume into their workflow and have the necessary tools to be able to handle that volume. I think the reception with respect to ClearRead CT in particular has been quite high, quite good.
Let's can you dive a little bit more into ClearRead CT? That's Riverain's flagship product, and it does support CT lung cancer screening. Can you talk a little bit about what ClearRead CT does, and then maybe we'll bounce back over to Chip and talk about how they're using it there at university hospitals.
So, one of the things that is truly unique about ClearRead CT and is very well received by the radiologists is what we call ClearRead CT vessel suppression. And so that particular function takes a standard chest CT and, using artificial intelligence, deep learning, suppresses the normal structures in that chest CT to improve the conspicuity of the disease. So, which leads to reduced oversight, leads to improved efficiency, and leads to improved accuracy as well. And so that's sort of kind of the foundation of ClearRead CT, is that what we call ClearRead CT vessel suppression. Then layered on top of that is ClearRead CT detect. So that is what takes that vessel suppressed representation, automatically detects segments, and then characterizes the lesions. And then the last component of ClearRead CT, which is what we call ClearRead CT Compare, it considers not only the current exam, but also the prior exam in conjunction with the current exam. So as people probably know, in terms of assessing likelihood of malignancy, that can be quite challenging. But one of the sort of, primary mechanisms to better assess likelihood of malignancy is to understand to what extent, if any, is that particular nodule growing at two different time points. So that's sort of the third component of ClearRead CT. So you have the vessel suppressed, which is a unique representation, facilitates detection, facilitates characterization. The automatic detection component, that's actually marking the location, segmenting the region of interest, characterizing that region of interest, and then not only for the current exam, but also considering the prior exam in conjunction with the current exam.
Great. And how does this integrate with a radiologist's workflow?
So it is basically agnostic with respect to the acquisition device. So the same solution is utilized independent of the manufacturer, but it's also agnostic with respect to the PACS review station. And so essentially what happens is we receive the native chest CT, we produce our content, right? So that'd be the vessel suppressed series, GSPS objects, DICOM structure report, and then we push that to the PACS archive, and so it sits in the patient file. And so when the radiologist opens the patient file, our content is already available to them. And so it's all of the reading is done within their sort of native workspace. And I think that has resonated quite well with the radiologists because they're doing such high volumes of exam. They don't want to lose the rhythm, right, from a reading perspective. And so that's very important.
Great. Chip, let's talk about your experience with ClearRead CT. Can you talk a little bit about how long you've been using it and the value you find in it? And then I guess we're going to look at some images in a bit.
Yeah, so I think for fully usable ClearRead CT and our use, particularly in the lung cancer screening programs, it's been about 1.5 years now. I've seen and we've utilized the ClearRead products before, and because I've done a lot of work with Steve and Riverain on both the X-ray and the CT side. So I saw the first iterations that I thought were very encouraging, but it really wasn't when I thought about our increasing load and our demands for our lung cancer screening. When I said this is really for me an absolute sweet spot for ClearRead CT to improve efficiencies and accuracies and reading times. So that's really what happened. And I think, and I would also echo a lot of things that Steve was saying. So Brian, if I went over to my workstation right now, and I looked at my lung cancer screening list, I'd see about 50 patients, about 50 patients a day. If I look at my PACS, this is all through the PACS and sort of regular workflow, we do lung cancer screening at 17 different locations. We've got 11 hospitals through the system with about 17 imaging centers. And they're all sending images to the central server and then processing the Riverain images and sending them to our PACS. So to me, the process is really transparent. And it doesn't matter from what source. And we have all the vendors, we've got all different slice thicknesses and techniques. But yeah, it is very agnostic. When I go to my reading station, the Riverain images are another set of images for this patient's file. It's not that I'm going into I'm going to a different workstation, or I have to like reboot something or go to a different app. It's sort of workflow. It's like workflow zero. It's just there. So that's the value.
Let's take a look at some images.
Okay. I thought I would just kind of focus on a couple different patient examples, because I wanted to focus on, I think, the particular challenges, and in general, but I guess I would sort of also comment on a couple of things about the Riverain approach, and in some ways I was trying to focus on interesting approach, which is to look at a conventional chest CT takes a huge amount of visual energy and time, because what you're doing constantly and mentally, when you're looking at chest CT, you're trying to separate all the vessels, and they were sort of throughout the images, and separate those vessels to the cancer or the nodule that you're concerning. And the amount of time that takes just to visually assess those images is amazing. And actually, I was thinking about how the ClearRead solutions, the applications of taking the vessels away, how it improves your efficiency, but also the amount of expenditure of visual and energy you take is just better. So I thought I would just kind of show you a couple different examples of that entity. So this is I thought I'd just show this. This is one of our patients from the screening program who turned out to have a cancer, just to show you the differences of how a standard axial slice of a low-dose chest CT. And what you see here is, obviously, you see all these branching vessels. But now sometimes it's pretty easy to see that it's a branching vessel, because a vessel, but we also know that the vessels also run on end sometimes. And how do you sometimes make the distinction between what's a vessel and what could be a nodule or a cancer? So if you look at here, this is sort of the post-process ClearRead CT. And you see that obviously a significant difference, because what you've really suppressed or removed all those crossing structures, all those vessels. And what they've left, which I could have, honestly, we know that these are the things that we can sometimes miss as radiologists in cancer screening, is what we call the central lung nodule. I could have missed this as just a big vessel, or maybe a lymph node. That's actually a pretty big cancer, but really much better seen when you take all that, what we call, as I joke with my residents, all this visual noise away from the effort to focus on the finding. And this is I thought I'd just show you that the follow-up. This is the original conventional CT scans with all the vessels and all the structures. This is the ClearRead. This is a suppressed image, suppressing everything that wasn't a vessel, which turned out to be, and here's the PET scan. Here's a PET scan showing that nodular density is active, and it turned out to be a carcinoid tumor. And and sometimes, as we sometimes joke about in radiology, I probably would have seen that at 8:30 in the morning, but what would happen at 6 o'clock at night with a stack of bunch of cases and actually pages and meetings? Maybe my ability to miss some of it, is definitely, again, I think my ability to consistently just improve my detection is better with a technique. So that's an example. And then I think what's also nice about, you can really, because of the application, you can reconstruct these ClearRead, the suppressed views in different planes as well. You're not just limited to the axial sleep. And this is a good example. Here's a standard coronal CT scan images on this patient. And I've just looked at the output in a coronal plane. And that was, so this is there are vessels in here, but this is actually the tumor, and here you can see the tumor. So again, so improving that detection, and in different planes, I think is really, to us, has been honestly transformative in our lung cancer screening program. So I thought I'd go on to just show you a second one. Similar in terms of the fact that this is going to be a subtle early central lung cancer, but to just show, I think, the strength of the application. So this is a patient came in for her lung cancer screening study. This is her initial screening. In her initial screening, there was not very much disease here. Here's her, and then these patients, as you know from the NLST and the recommendations, they come back every year. So you do have a comparison, hopefully, and certainly with the ClearRead we have a comparison. This is the follow-up surveillance scan. Now again, maybe I would have been good at 8 o'clock in the morning, but at 4 o'clock in the afternoon, I may have missed the fact that there's subtly that area of the lung and the hilum was a little bit bigger than it was a year ago. Now that's on the standard images, and this is the ClearRead CT showing the difference. So what you've taken away and suppressed all the vessels, that was clearly an abnormal lung nodule here. And if you retrospectively say, oh yeah, there it was, but it's pretty subtle differences. But it turns out to be a pretty significant disease. And here again, here's some different ways that we can see this. Here's the suppressed images. This is as Steve alluded to, the ClearRead compare. This was our initial, or sort of the follow-up surveillance scan, but there was no match. Basically, the community saying there was that nodule or that abnormality was not there a year ago. So this is clearly an interval change, and you can see a volume of this down here with a diameter, and there wasn't a match last year. And then finally, I show you the correlation again. ClearRead CT, the PET scan clearly positive. It would turn out to be an early squamous cell cancer. So I think these are two good examples of sort of the technology, and particularly I think for radiologists, these are, particularly for cardiothoracic or any general radiologists, these are clearly the kind of what we call our danger zones for lung cancer detection, is those central lesions, and how I think that sometimes being able to tease out what is a lesion versus a vessel versus a cancer. So I thought these were good examples.
Great. Those are amazing. Those are really amazing. Well, we're getting pretty close to time. I'd like to give you both a chance to share some concluding thoughts about, the role of CT lung cancer screening in healthcare today, and maybe where you see things going with ClearRead CT. Chip, any closing thoughts for our audience?
So my closing thoughts for the audience, for the first principle of lung cancer screening, I think it's important to recognize that it does take effort, and it does take time, it does take follow-up, and to make sure that sort of at the front end, try to really make sure that you build the infrastructure and the support, and both human and technological support, to be able to do this. It's going to be important. I think particularly, I think that in anticipating as those numbers and volumes go up, we're all going to need more help. And I think the efficiencies with this technology for Riverain and the ClearRead really helps our efficiencies, and sort of, I think, anticipates the potential increased volumes as this happens. I also am really encouraged, and we'll be talking with Steve, is that what I like is I think that there are a lot of the output, and I showed you some examples, and again, looking at the images, it's really sort of it's a workflow neutral zero in terms of added, workstations or applications or closing is one thing important. But I think also, we can get much even more efficient and more creative with Riverain about the outputs, and just improving on our efficiencies to act on some of these patients.
Great. Steve, any parting words from you? Any advice to someone that's thinking about getting started with CT lung cancer screening?
Well, first of all, I'd just like to thank you for giving me the opportunity to talk a little bit about ClearRead CT. I think, I think we're still in the very early innings, right, with respect to lung cancer screening. I think, the data shows that although the base is relatively low, it is accelerating, right, in terms of uptake. And so I think the challenges that radiologists have today, that's just going to continue to increase. And so from our sort of perspective and sort of aspiring to provide tools that really sort of improve patient outcomes, but also improve the radiologists, right? Improve the lives of the radiologists, right? In terms of allowing them to do more effectively and more efficiently. But we'll just continue, we'll continue to evolve ClearRead CT for the lung cancer screening use case. And we'll bring additional applications into the market that will address comorbidities that commonly exist with lung cancer screening patients. And so, I think the goal is to provide a set of tools that are clinically effective and really deliver on the value that they were intended to deliver on when they were built.
Great. Well, that's something to look forward to. Well, I'd like to thank Dr. Chip Gilkeson of University Hospitals and Steve Worrell of Riverain Technologies for being with us today. Gentlemen, thanks so much for the discussion today.
All right. Thank you.
All right. Signing off for the Imaging Wire, my name is Brian Casey.